Welcome to this podcast on myocardial metabolism and myocardial preservation. My name is Dr. J. Thomas Murphy, and I am in the Department of Anesthesiology at the University of Kentucky. This podcast is being presented in August 2016 for the PGY3 CA2 first rotation residents. The resources for this podcast are found primarily in the 5th edition of Hensley, A Practical Approach to Cardiac Anesthesia. I suggest that you read the text references before watching this podcast. The educational objectives of this podcast are as follows. First, to be able to recall relevant cardiac histology and gross anatomy as relates to the topic. Second, to recall the normal metabolism of the heart, that is ATP production. Third, to explain the factors which affect myocardial oxygen supply and demand. Fourth, to recall the normal substrates for aerobic myocardial metabolism and anaerobic myocardial metabolism. Fifth, to explain the rationale of aortic cross-clamping and cardioplegia. And finally, to discuss alternatives to aortic cross-clamping and anterograde cardioplegia. Now let's deal with the second topic of this podcast, myocardial protection. The main reference for this is Chapter 23, the intraoperative myocardial protection, found in Hensley. And I suggest you review the key points in that chapter before and after reading the chapter and viewing this podcast. I'll just bring up a few points as we peruse the chapter. And historically, excessive doses of potassium resulted in stone heart and cardiac failure. Retrograde cardioplegia was first performed in the 1950s with direct cannulation of the coronary sinus. Obviously not for coronary revascularization, as that operation had not been yet invented, at least not in the current form. It is well known that hypothermia is protective, and if you think about the 50% reduction in metabolism with a 10-degree decrease in temperature, you can see why. In the history of myocardial protection, potassium made a resurgence in the 1970s with a lower concentration than had been previously used. And according to Hensley, blood cardioplegia became popular in the 1970s and 1980s with a ratio of 4 parts of blood to 1 part cardioplegia, with an ultimate potassium concentration in the region of 16 to 20 milliequivalents per liter. Now, to get down to basics, myocardial ischemia occurs when demand exceeds supply, and infarction occurs when this situation persists for a prolonged period. Oxygen delivery may be inadequate because of a decrease in perfusion pressure, hypotension, decreased aortic diastolic pressure, or through coronary stenosis, or through an increase of LV-EDP, or a combination of these factors. It is said that the right ventricle may be less susceptible to injury since flow to its cells occurs during systole, but this is not true during with patients who have severe pulmonary hypertension. I think it is worthwhile reviewing the mechanism of myocardial ischemic injury, and the prime ones are listed on this slide and extracted from your textbook, and they include the depletion of high energy phosphates, intracellular acidosis, calcium, and this is a complex issue, oxygen-derived free radicals, the immune system with complement activation, white blood cells and the myocardial cell leukocyte interaction, and myocellular edema. Just to reiterate and remind you of the difference in oxygen consumption as affected by the work performed by the heart. The oxygen consumption is 8 mils per 100 grams of beating heart, 5.6 mils per 100 mils of empty beating heart, and 1.1 mils of oxygen per 100 grams of potassium arrested heart. So quite a significant difference between the beating heart and the arrested heart. Some of the interventions that one would consider before the onset of ischemia would be to minimize ischemia by using nitrates and reducing end diastolic pressure, to maximize oxygen delivery with supplemental oxygen, the use of anticoagulants such as heparin to prevent thrombosis, the use of anxiolytics to reduce heart rate and blood pressure, and the use of the intra-aortic balloon pump to decrease afterload and to increase aortic diastolic pressure. Of course, beta blockade reduces myocardial oxygen consumption. In the operating room, the diagnosis of acute ischemia should promote emergent revascularization with consideration of change in surgical plan, perhaps the selection of more rapid venous conduits instead of an arterial conduit. Other somewhat controversial approaches to prevention of ischemia in the intraoperative arena include nutritional repletion. As the depleted heart has little reserve, it is possible that glucose, insulin, potassium could preserve myocardial energetics, and it is stated that GIK has been shown to reduce complications. Other interventions include the avoidance of ischemia by performance of surgery on a beating heart with maintenance of perfusion pressure, for example with an intra-aortic balloon pump, using cardiopulmonary bypass without the cross clamp, and simplifying the systemic effects of cardioplegia in selected patients, and taking advantage of the empty beating heart and its reduced oxygen consumption. The avoidance of normothermic fibrillatory arrest is particularly important, as it has a very high oxygen cost. The prevention of ventricular distension is also important, though this is difficult for the surgeon sometimes because the left ventricle is posterior and it can be difficult to monitor. We can help by making sure that the PA pressure is displayed and monitored and considered as a potential indicator of left atrial pressure and left ventricular and diastolic pressure. As well, the DEE can sometimes detect left ventricular distension, and this information can be communicated to the surgeon. I have seen myocardial preconditioning performed, which is also called ischemic preconditioning, and I have seen this done even in this century at UK, although it is not currently performed by any of the surgeons at UK, and this involves cycles of ischemia by clamping the coronary artery flow and releasing it with the intention of preventing ischemia while the heart is cross-clamped. Another intervention which is suggested is warm induction of cardioplegic arrest, and this refers to the use of normothermic cardioplegia for the first dose. This varies by surgeon and institution, and it may be something which is employed to a greater or lesser extent at UK. Now, diastolic arrest is the most common method of myocardial protection when a cross clamp is used, and this refers to the use of a potassium-containing solution such that depolarization of myocardial cells occurs. Sodium channels close and the heart remains unexcitable. Cardioplegia does wash out of the extracellular space, and the heart repolarizes, and another dose of cardioplegia becomes necessary. There are two routes of cardioplegia delivery, and they are antegrade, and the rate of administration is in the area of 150 mils per minute per meter squared and adjusted to root pressure. This is typically 10 to 15 mils per kilo, such that a 70 kilo patient might receive 1,000 mils of cardioplegia over about 3 minutes. In addition, when the aortic root is open and the coronary ostia are visible, the surgeon can use special handheld cannulae to deliver cardioplegia to each coronary artery in turn, such so that antegrade cardioplegia can be effectively delivered in the case of aortic insufficiency. As mentioned earlier, retrograde cardioplegia has been around for a number of years, and the pressure which is recommended is fairly low, in the order of 40 millimeters of mercury, and it is stated that its primary advantage is in valvular procedures. However, certain surgeons will use retrograde cardioplegia with coronary revascularization, and both kinds of delivery, antegrade and retrograde, can be combined in a given patient. The frequency of cardioplegia is dependent on myocardial temperature. If the heart is warm, more frequent cardioplegia may be required, and if non-coronary collaterals and higher perfusion pressures result in washout of cardioplegia, more frequent dosing is also required. There are many additives to cardioplegia. Anecdotally, I can tell you that in the austere environment of Saudi Arabia, we used sodium chloride with potassium and a small amount of bicarb to adjust the pH, and it was quite effective. We used no other additives. However, in the world of cardiac surgery and myocardial preservation, many additives are used. And Hensley makes the statement that the cardioplegic solution must balance the goals of simplicity, cost, and effectiveness. Many of the additives are found in the blood anyway, and it is not known for certain whether or not these additives improve outcome. Nonetheless, there are different kinds of cardioplegia, and one kind which is called intracellular, which mimics the intracellular electrolyte composition, and therefore is a low sodium cardioplegia, is primarily used for organ preservation in North America. However, intracellular cardioplegia, intracellular electrolyte composition, is more common in Europe. What we use is termed extracellular, and the electrolyte concentration is similar to serum, but with a high potassium level. The initial concentration of potassium is in the region of 8 to 30 milliequivalents per liter, with lower concentrations possible if electrical arrest persists. Blood cardioplegia is now most popular form of cardioplegia as compared to crystalloid cardioplegia in North America, but it's stated that there's no difference in mortality between the two. Now, as far as calcium is concerned, it's felt that limiting the calcium helps to maintain arrest. Cardioplegic solutions that are calcium free are bad, and while it used to be routine for calcium to be given immediately after cross clamp removal, this is no longer favored. A 15-minute interval between cross clamp removal and administration of calcium is recommended in Hensley. However, this could be influenced by blood gases, ionized calcium level, and co-administration of saturated blood products, as well as the timing of cross clamp removal and separation from bypass. Overall, it has been long held and believed that reperfusion of the heart with a high calcium concentration could lead to reperfusion injury, and likewise immediate reperfusion with a high blood pressure is not recommended. Magnesium is a variable additive, and in the 1990s it became quite common to use magnesium, and since it counters the effects of calcium, it is kind of it's fairly easy to imagine why it became popular. Other additives include glutamate and aspartate, and as they are intermediates in the Krebs cycle, they may help to restore high energy phosphates. Some of the other strategies which may be employed during reperfusion include substrate washout, which can occur with intermittent cross-clamp removal, the use of terminal warm blood cardioplegia, also called hot shot. As mentioned a few slides back, a controlled reperfusion pressure, that is using a 40 millimeter maximum during the first 2 minutes of reperfusion, with a subsequent target of a mean pressure of 70 millimeters of mercury is recommended. It is most important to avoid ventricular distension, and this can be accomplished by maintaining full bypass with right heart decompression, the use of right superior pulmonary vein vent, and the assiduous prevention and treatment of ventricular fibrillation. Other interventions during reperfusion include de-airing of the heart, and the prevention of coronary embolus, air embolus, can be accomplished by using carbon dioxide flooding of the surgical field, and transesophageal echocardiography can be used to detect intracardiac air, and can be used to diagnose acute changes in wall motion, which could be due to an air embolus. Well, this is the last slide of the podcast, and I thank you for listening and for using your textbook in this review of myocardial metabolism and intraoperative myocardial protection.